proximal as well as distal locking by freehand technique. And number 3, we have added a color-coded tibial nail extractor or more improved version of the color-coded tibial nail extractor called RCT nail introducer compositional to introduce the nail inside the intermedullary canal in proper position. So these 3 changes makes this innovative technique as a very, very cost-effective way of doing suprapatellar nailing of tibia. So friends, this is not a Jogaru technique. This has very strong mathematical or scientific basis. After jumping so many steps of mathematical equation, we have come to know that the success of interlocking nailing is equal to K into C into P into Z. Whereas K is the expertise in the art of the freehand technique of locking, whereas the C, P and Z are the respectively the availability of the C arm in your OT and protective sleeve in your special instrument set and jig in your special instrument set. If you increase the value of K to such an extent that the jig becomes 0, that is dependence on the jig becomes 0, this creates a scenario where the surgeon has mastered the freehand technique of locking and can perform both proximal as well as distal locking without the jig. So this is the mathematical basis. We conducted a study between March 20 to March 22 5 on 100 cases of non-articular fracture of the tibia done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So along with the other instruments, we had 2 pilot instruments. Number 1, a color-coded tibial nail extractor, which is present in infrapatellar nailing set, and a more improved version of the color-coded tibial nail extractor called RCT nail introducer composition to introduce the nail. This is the skin incision, you can see the transverse incision has been given, but you can give vertical incision also. And this is the innovative part of this innovative. Second picture shows the innovative part of this innovative technique, the introduction of the trocar and protective sleeve probe PFN A2 set inside the retropatellar space. And the third picture shows the innovative part of this innovative technique, that is the proximal locking by freehand technique. So after making a hole just medial to the lateral tibial spine, we introduce a malleable guide wire. After percutaneous reduction of the fracture with the percutaneous forceps, and after serial reaming, we mounted a appropriate size nail over the color-coded tibial nail extractor or RCT nail introducer composition, and finally we introduced the proximal as well as distal locking by freehand technique. So this is the flow diagram, nothing to repeat it again, and this is the post-operative follow-up steps. Again, you all are aware of this. It is same as the infrapatellar nailing of tibia. No patient complain of knee pain in our series. All patients get full range of movement in our series by 16 weeks. At final follow-up, 4 cases found excellent results, whereas 30 had good results, whereas 2 had subacute infection at the screw site and 1 had infected non-union. The average time of union was 80 plus minus 10 minutes, whereas average fluoroscopy time was 38.5 plus minus 6.5 seconds. All patients followed 2, 3, 6, 8 and 12 weeks, and the average time of the union was 8 weeks post-surgery, whereas complete union occurred by 12 weeks in all our cases. These are the few cases, clinical as well as radiological pictures of the few cases done by Dr. Thakur innovative technique of suprapatellar nailing of tibia. So the number of studies done on this innovative technique is small. I think this is the only study done by me, although good number of patients were included. The study was not comparative with the standard technique, so a status of cartilage over the fat line trochlea was not evaluated in this study. Because furthermore study is required to compare this innovative technique. We had a high-tech presentation in IOACON and found a space in International Journal of Orthopedic Sciences. You can see, and this is a video we don't have time to show you. So the take-home message is this technique could prove a boon for small and medium-class hospitals situated in BSC, Great Town, in India and poor countries like Bhutan, Nepal and Bangladesh, where the allocation towards the health is very, very low. So this could prove also a very useful technique for Ayushman Bharat Yojana, which is the dream project of our Prime Minister, Shri Narendra Modi. Thank you very much for patient hearing.
Thank you. If you're using AI in your workflow, then you might be facing these 3 major challenges. First, crafting prompts that actually get you the results you want. Second, knowing which AI tools to use for specific tasks in your workflow. Third, integrating AI seamlessly to save time rather than waste it. If you're stuck at any of these three hurdles, then I'd like to invite you to my Gen AI workshop that's already helped over 2 million professionals transform their productivity. In this workshop, I'll give you some insane strategies to overcome these hurdles. You'll learn AI frameworks and strategies and discover 25 plus AI tools, including ChatGPT, Gemini, Copilot, Midjourney, that will help you automate 50% of your workflow, save 2-3 hours every day, 10x your productivity, and show you what else is possible with AI tools that you can't even imagine right now. If you're interested, then click below and join my workshop right now. See you on the other side.
Hi. So can you tell me your name and which company you work at?
My name is Rashmi and I work at TCS.
Interesting. So I'm going to show you a dashboard, and could you let me know how long you would take to make something like this?
There are many steps involved, right? Like you'll have to probably organize the data and then like apply some formulas, I'm guessing, and then to make the chart and then analyze it. I think 5 to 6 hours roughly.
Okay. So will you join my course if I make this exact same dashboard within 2 minutes?
What? How is that even possible? If you can do it, then yeah, sure, why not?
The registered teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing is unlike conservative management. It provides stable fixation and early mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on out-the-state height was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement. And the jet type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and a screw. So these are the already explained. The simple fracture were taken into consideration. Displaced simple fractures are spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies supine if you are affected, lip elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed width. The incision is small incision has a transverse or longitudinal incision about 1 to 1.5 centimeters. Just lateral to the sternoclavicular joint is given, adapted, making an incision with the help of drill bit, and then you make this whole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense snelling after close reduction or mini incision reduction. So the immediate cost of pain management and immobilization at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, at 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bypass, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nerve, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of 15B1 fracture treated by titanium elastic nerve, yet another case of 15B1 fracture treated by titanium elastic nerve. These are the 15B2 fracture. This is 15B3 fracture treated by titanium elastic nerve. Ideally, it should be treated by open reduction and internal fixation, but we did tense beautiful radiological union. This is the functional result. You can see. So the time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of distress fracture of the take-home message is tense snelling is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science.
अगर आप बिजनेस कर रहे हो तो अगला 1 मिनट आपका ईगो हर्ट कर देगा, तो कमजोर दिल वाले ना देखें। भारत का व्यापारी खुद को समझता है बिजनेस का मालिक, पर मालिक नहीं है। या तो वो है रजनीकांत, या है रामू काका, या है चौकीदार। अब आप पूछोगे ये क्या होता है? रजनीकांत तो ये होता है कि बिजनेस के सारे काम कौन करेगा? मैं। सेल मैं करूं, परचेज मैं करूं, बैंक में जाऊं, सीए से बात मैं करूंगा, कस्टमर को मैं मनाऊंगा, पैसे लेके मैं आऊंगा, अत्र तत्र सर्वत्र मैं ही रजनीकांत। सेकंड बिजनेसमैन होते हैं रामू काका। वो अपने एम्प्लॉय के ही एम्प्लॉय होते हैं। नॉर्मली एम्प्लॉय का काम होता है आपकी काम में हाथ बटाना, पर ये लोग एम्प्लॉय के काम में हाथ बटाते रहते हैं। एम्प्लॉय का काम होता है आपका टाइम बचाए, पर वो आपका टाइम खाता रहता है। एम्प्लॉय का काम होता है आपको 2 पैसे कमा के दे, पर आप पैसे कमा के एम्प्लॉय को तनख्वाह में दे देते हो। आप एम्प्लॉय को काम देते हो, ट्रेनिंग देते हो, पीछे पड़ते हो, काम करने के पैसे देते हो, और लास्ट में काम खुद ही करते हो। इसको कहते हैं रामू काका। कुछ है चौकीदार, वो कहते हैं भाई साहब मेरे ऑफिस में काम तभी होता है जब मैं जाके गल्ले पे बैठूं या मेरी ऑफिस में चेयर पे बैठूं। अगर मैं नहीं होऊंगा पीछे से कुछ नहीं होगा, मुझे मेरे आदमियों की चौकीदारी करनी पड़ती है, मालिक तो मैं हूं ही नहीं। इन तीनों में से किसी स्टेज पे अगर आप खुद को महसूस करते हो तो रुको, अगले 1 मिनट में सॉल्यूशन मिलेगा। और आपको लगता है सब चंगा सी तो आगे बढ़िए सर, आपको भविष्य के लिए बेस्ट ऑफ लक। तो पहली बात आपको सुकून की बता दूं कि आप अकेले नहीं हो, 90% भारत के व्यापारी ऐसे ही हैं। एम्प्लॉय डिपार्टमेंट में हाल ऐसा है, ढंग के लोग मिल नहीं रहे, जो लोग मिल रहे हैं वो काम नहीं कर रहे, और जो काम कर रहे हैं वो छोड़ के जाने की धमकी देते हैं, और जो लोग छोड़ के जाते हैं वही कंपटीशन बन जाते हैं। और इनको संभालने के चक्कर में हम ऑफिस, दुकान, फैक्ट्री से निकल ही नहीं पाते। हम कस्टमर से ज्यादा टाइम एम्प्लॉय को दे रहे हैं। पहली बात तो पैसे कुछ बन नहीं रहे, और अगर गलती से 2 पैसे बने भी है, खर्च करने का टाइम नहीं है, क्योंकि सुबह शाम तो ऑफिस में हाजिरी लगानी है। सेल्स के हाल ये है कि भैया ऑफिस में, दुकान में, फैक्ट्री में इतना बिजी है कि बाजार में क्या चल रहा है पता ही नहीं, नए ट्रेंड में क्या हो रहा है पता ही नहीं, ब्रांड कैसे बनाए पता ही नहीं। तो नए के पीछे भाग रहे हैं तो पुराने छूट जाते हैं, पुराने को रोक के रखते हैं तो नए नहीं आते। पुराने को रोकने के लिए डिस्काउंट देना पड़ रहा है, उधारी देनी पड़ रही है, और उसके चक्कर में हाथ में पैसा ही नहीं बच रहा। तो ना सेल बढ़ रही, ना प्रॉफिट बढ़ रहा, हाथ में है सिर्फ लोन और भगवान की दुआओं से काम चल रहा है। तो मेरा एक ही सवाल है कि एम्प्लॉय, फाइनेंस, मार्केटिंग सब में तो मर रहे हैं, फिर हम क्या खाक व्यापार कर रहे हैं? पर राहुल जी क्या सबकी जिंदगी ऐसी है? नहीं, मैंने कहा ना 90% की है, 10% की जिंदगी कुछ अलग है। उनको चौकीदारी की जरूरत नहीं है, वो ऑफिस, दुकान, फैक्ट्री हो या ना हो, पीछे से सारा काम चलता है। उनकी टीम बढ़िया है, उनके पीठ पीछे अच्छा काम करती है। अब क्योंकि वो फ्री हैं, वो सेल पे भी ध्यान दे पा रहे हैं, नए प्रोडक्ट जोड़ रहे हैं, नए कस्टमर जोड़ रहे हैं, और जब नए नए कस्टमर आ रहे हैं तो पुरानों पे डिपेंडेंसी नहीं है, तो पुराने भी नखरे नहीं दिखा रहे, टाइम से पैसा दे रहे हैं, और जो नाटक कर रहे हैं उनके लात पड़ रही है। और सबसे इंपॉर्टेंट चीज, इतना सारा काम करने के बाद भी मोस्टली फ्री रहते हैं, दिन में 2-3 घंटे से ज्यादा काम नहीं करते। ये समाज में भी एक्टिव हैं, घर में भी एक्टिव हैं, खेल भी रहे हैं, जिम भी जा रहे हैं, सब कुछ मजे कर रहे हैं। अब आप सोचोगे राहुल जी हम तो 10-10, 12-12 घंटे काम कर रहे हैं तो बिजनेस संकट में नहीं आ रहा, ये 10 गुना बड़ा बिजनेस 2-3 घंटे में कैसे मैनेज कर लेते हैं? आपके दिमाग में अगर ये सवाल है तो आज आपका शुभ दिन है। मैं हूं राहुल मधोदिया, इंडिया का मोस्ट फॉलोड चार्टर्ड अकाउंटेंट। मेरे सोशल मीडिया पे 1.5 करोड़ से ज्यादा फॉलोअर्स हैं, और मैं एज अ बिजनेस कोच अब तक 3.5 लाख से ज्यादा बिजनेसमैन को ट्रेन कर चुका हूँ। मैं ये ट्रेन करता हूँ कि भैया आपके जीवन में ये सारी कमियां क्यों हैं, इसके पीछे कारण क्या है और कैसे ये सॉल्व होगी। तो ये बड़ी बड़ी कंपनियों के सीईओ जो काम कर रहे हैं, इनका सीक्रेट क्या है और कौन कौन से ऐसे स्किल हैं जो एज ए बिजनेसमैन आपको सीखने चाहिए। ये मैं करता हूं एक मेरी मास्टर क्लास के माध्यम से, जिसका नाम है व्यापारी टू सीयू। ये क्लास रेगुलर बेसिस पे चलती रहती है। हो सकता है आज रात को 7 से 9, हो सकता है कल सुबह 7 से 9, हो सकता है अगले हफ्ते हो। अब जब भी आपको मिले आपकी किस्मत। बट आपको एक ऑफर में जरूर दे सकता हूं कि अगर आप अभी इसको रजिस्टर्ड करते हैं तो आपको 2 ई बुक फ्री मिलती है, एम्प्लॉय मैनेजमेंट और माइंडसेट की। और 24 घंटे के अंदर अंदर अगर आप क्लास अटेंड कर पाते हैं तो आपको 2 ई बुक और फ्री मिलेगी, फाइनेंस की और मार्केटिंग की। तो रजिस्टर्ड करने में फायदा है, अटेंड करने में डबल फायदा है। तो रजिस्टर्ड कीजिए अभी के अभी। और क्योंकि मैं जानता हूं भारत की जनता है, आप पहले इस्तेमाल कर फिर विश्वास करते हैं, तो आप पहले ये 2-3 घंटे की जो हमारी मास्टर क्लास है इस
17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a Karachi fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the compressed forearm fracture and dislocation, which we called the Karachi fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture, a 17-year-old gentleman, and the forearm Karachi fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this Karachi fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for Karachi fracture, and this is not reported in any literature. For the such a severely displaced fracture, the tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Karachi fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this left radius, the Karachi fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Karachi fracture. So, but I left it and wait for it. This is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 month. You can see the After waiting 11 months, the union is complete in both the fracture. The secondary canals have been formed. It was not hypertrophic non-union, it was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, erection and extension all are present. And the tense swelling provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained and DR, UJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirms that interlocking nailing of femur and TENS yields higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences.
Save time creating content and generate a high-quality clone of your voice with 11 Labs. Change the way you record podcasts, voiceovers, and branded content with the
provide stable fixation and earlier mobilization and reduces the risk of non-union and malunion. TENS is less invasive, resulting in smaller incision. After the study between March 2020 to March 2025, on 25 cases of the displaced fracture of the clavicle, the age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nailing. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture side, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicated fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is a transverse and short of the fracture. So the patient lies supine with affected limb elevated and hanging outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone owl. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is the very crucial step. And then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up was the 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the 1ST surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did, the 15B1 fracture again treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site, there is secondary callus formation. 1 bump is due to secondary callus formation, and other at the entry site, you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS snelling is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here.
सुनिए, मैं आपको एक बात बताता हूँ. मुझे समझ में आया कि बिजनेस क्या नहीं होता है. मैंने रिटायरमेंट
ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापैटरल नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है. इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलेबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सी आर्म के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सी आर्म को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है, अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को। और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से सी आर्म को एडजस्ट किया जाता है कि वो गोल दिखे। और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सी आर्म को एडजस्ट किया गया है। और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला। Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blunt dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the pyriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture, and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the epi view in correct position. And in lateral view also, it has gone in position. That is at the point anterior 2/3 and the junction of the anterior 2/3 and posterior 1/3 of the dental proctor. So after confirming it, I am going to introduce still I am introducing the bone out inside the intermedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intermedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we remove this bone out, and then after reduction of the fracture, with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal segment. And after introduction of the guide wire, we are going to ring the medullary canal with the help of hand lever. And it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nail process with the help of the F tool. During reading process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. And I am doing reading with a 10 millimeter remote, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in amplitude, and also in lateral